Hello friends, welcome to the channel Homeopathic Soul. So today we are going to learn about the bone and their attachment. In a entrance exam or in any competitive exam of a homeopathy, muscle attachment is always remain a favorite MCQ. So let's start. So uh, the first bone of the upper limb that we are going to learn is the clavicle. Clavicle is a long bone. The clavicle transmits the weight of the limb to the sternum. Bone, that is the clavicle, has a shaft which is a cylindrical. The two ends, that is the lateral end and a medial end. Then the side determinations are: lateral end is a flat one, the medial end is a large and quadrilateral. Shaft is slightly curved. Inferior surface is grooved longitudinally into its middle one third. Peculiarities of the clavicle are: it is the only long bone that lies horizontally. It is subcutaneous throughout, the first bone to start the ossify. So clavicle is the first bone that in our body that start to ossify. The only long bone which ossify in a membrane. Clavicle is the only long bone which has a two primary centers of the ossification. There is no medullary cavity into the clavicle. Occasionally, it pierced by the middle supraclavicular nerve. The features of the clavicle are: shaft is divided into the lateral one third and the medial two third. Lateral one third is flattened from above downward. The lateral one third has a two border, that is the anterior border and a posterior border, and the two surfaces, that is the superior surface which is subcutaneous and the inferior surface. Inferior surface of the lateral one third has a elevation which is called as a conoid tubercle, and it have the ridge, the trapezoid ridge. Then the medial two third. Medial two third is a rounded and having the four surfaces. The four surfaces of the medial two third of the shaft are: anterior surface which is convex forward, the posterior surface which is smooth, superior surface which is rough into its medial part, and the inferior surface which is rough oval impression at the medial end. Then the lateral half of this surface has a longitudinal subclavian groove. The nutrient foramen lies at the lateral end of the groove. Then the lateral end. Lateral end is flattened from above downward, and the medial end is a quadrangular. Then the most important part is attachments. So lateral one third of the shaft. The anterior border gives origin to the deltoid muscle. Posterior border provides an insertion to the trapezius. A conoid tubercle and the trapezoid ridge gives attachment to the conoid and the trapezoid part of the coracoclavicular ligament. Then medial two third of the shaft. In a medial two third of the shaft, the anterior surface gives origin to the pectoralis major. The rough superior surface gives an origin to the clavicular head of the sternocleidomastoid muscle. The subclavian groove gives insertion to the subclavius muscle. Posterior surface gives origin to the sternohyoid muscle. Subclavius muscle act as a cushion. So remember this. Then the nutrient foramen transmits a branch of the suprascapular artery. Then ossification of the clavicle. How it get ossify? So the clavicle is the first bone in the body to start ossify. It ossifies in a membrane except a medial end. So throughout the clavicle ossify into the membrane except its medial end does not ossify in a membrane. Then the clinical anatomy about the clavicle. So clavicle is commonly fractured by falling on the outstretched hand. The most common site of a fracture is the junction between the two curvature of the bone. Then the junction between the two curvature of the bone is the weakest point of a clavicle. Then the term cleidocranial dysostosis. So in this condition, the clavicle may be congenitally absent or imperfectly developed. Then here the clavicle ends, and the next bone we will going to learn is scapula. So let's start with the scapula. It is the thin bone that placed on a posterolateral aspect of the thoracic cage. It has two surfaces, three borders, three angles, and the three processes. Then the side determination of the scapula. Lateral or a glenoid angle is a large and it bear a glenoid cavity. The dorsal surface is a convex and divided by the triangular spine into the supraspinatus and the infraspinatus fossa. The thickest lateral border runs from glenoid cavity above to the inferior angle below. So lateral border is the thickest one in the scapula. The features of the scapula. The surfaces. Costal surface or a subscapular fossa. There are actually two surfaces to the scapula: the costal surface, which is also called as the subscapular fossa, and the dorsal surface. It get divided into the two fossa again, that is the supraspinatus and the infraspinatus, and these get divided by the spine of a scapula. Then the borders. The superior border is a thin and it is a shorter. The lateral border is the thick one and the medial border is the thin. Then the angles. Superior angle is covered by the trapezius muscle, inferior angle get covered by the latissimus dorsi muscle, and the lateral or a glenoid angle is broad and it bear a glenoid cavity or a fossa. The processes. There are three processes to the scapula, that is the spinous process, acromion process, coracoid process. Then attachment, the favorite part. The subscapularis arises from the medial two-thirds of the subscapular fossa. Supraspinatus arises from the median two-thirds of the supraspinatus fossa. Infraspinatus arises from the median two-thirds of the infraspinous fossa. The deltoid arises from the lower border of the crest of the spine. Trapezius inserted into the upper border of the crest of the spine. The serratus anterior inserted along the medial border of the costal surface. The long head of the bicep brachii arises from the supraglenoid tubercle and the short head from the lateral part of the tip of the coracoid process. The coracobrachialis arises from the medial part of the tip of the coracoid process. The pectoralis minor inserted into the medial border and the superior surface of the coracoid process. The long head of the tricep brachii arises from the infraglenoid tubercle. Teres minor arises from the upper two-thirds of the rough strip of the dorsal surface along the lateral border. Teres major arises from the lower one-third of the rough strip on the dorsal aspect of the lateral border. The Levator Scapulae is inserted along the dorsal aspect of the medial border. The rhomboid minor is inserted into the medial border opposite to the root of the spine. Rhomboid major is inserted into the medial border. Inferior belly of a homohyoid arises from the upper border near the suprascapular notch. Then the ossifications of the scapula. Scapula ossify from the one primary center and the 7 secondary center. Then clinical anatomy about the scapula. The paralysis of a serratus anterior muscle causes the winging of the scapula. Scaphoid scapula is a condition in which the developmental anomaly in which the medial border is a concave, which is called as the scaphoid scapula. Then our next bone that we are going to learn is humerus. So let's start with the humerus. The longest bone of a upper limb. Its side determination are: upper end is rounded to form the head. the head of the humerus. Head is directed medially, upward and backward. The line separating the head from the rest of the upper end, it is called as the anatomical neck. The lesser tubercle is an elevation on the anterior aspect of the upper end. Greater tubercle on a lateral part of the upper end. So greater tubercle is present on the lateral part of the upper end and the lesser tubercle on the medial part. The intertubercular sulcus or a bicipital groove separates the lesser tubercle medially from the anterior part of the greater tubercle. The sulcus has a medial and the lateral lip. The narrow line separating the upper end of the humerus from the shaft is called as the surgical neck. The morphological neck lies 0.5 cm above the surgical neck. Then the shaft. Shaft has three borders, the anterior, lateral and the medial border, and has three surfaces, that is the anterolateral surface, anteromedial surface and the posterior surface. Then the lower end. Lower end has a capitulum, that is rounded projection, and it have a trochlea, it is a pulley shaped surface. The non-articular part of a lower end is capitulum and trochlea is a articular part, and the non-articular part are medial epicondyle, lateral epicondyle, lateral supracondylar ridge and the medial supracondylar ridge. The coronoid fossa is a depression just above the anterior aspect of the trochlea. Radial fossa is a depression present just above the anterior aspect of the capitulum. Olecranon fossa lies just above the anterior aspect of the capitulum. Then the attachments of the humerus. Multipinnate subscapularis inserted into the lesser tubercle. Supraspinatus inserted into the uppermost impression of the greater tubercle. And the infraspinatus is inserted into the middle impression of the greater tubercle. So supraspinatus and the infraspinatus have their insertion on the greater tubercle. Then teres minor inserted into the lower impression on a greater tubercle. Pectoralis major inserted into the lateral lip of the intertubercular sulcus. The latissimus dorsi is inserted into the floor of an intertubercular sulcus. Teres major is inserted into the medial lip of the intertubercular sulcus. Then the content of the intertubercular sulcus are the tendon of a long head of a bicep brachii and the ascending branch of the anterior circumflex humeral artery. And then the deltoid is inserted into, so there are two content of the intertubercular sulcus. So this is the point to be remembered. Then deltoid is inserted into the deltoid tuberosity. Coracobrachialis is inserted into the rough area on the middle of the medial border. The brachialis arises from the lower half of a anteromedial and the anterolateral surface of the shaft. Brachioradialis arises from the upper two-thirds of the lateral supracondylar ridge. Extensor carpi radialis longus arises from the lower one-third of the lateral supracondylar ridge. The pronator teres arises from the lower one-third of the medial supracondylar ridge. Superficial flexor muscles of the forearm arises from the common origin of the anterior aspect of the medial epicondyle, the common flexor origin. Superficial extensor muscle of the forearm and the supinator have the common origin from the lateral epicondyle, that have the common extensor origin. So on the anterior aspect of the medial epicondyle, all the flexor muscles of the forearm get common origin, and on the lateral epicondyle all the superficial extensor muscle get the common origin. Then the anconeus arises from the posterior surface of the lateral epicondyle. Ossification of the humerus. Humerus ossify from one primary center and a 7 secondary center. Then the clinical anatomy of a humerus is the common site of a fracture of the humerus are the surgical neck, shaft, supracondylar region. It is common. A supracondylar region fracture is common in a young peoples. Then the supracondylar fracture may causes injury to the median nerve. It may lead to the Volkmann's ischemic contracture. This is due to the occlusion of a brachial artery. The head of a humerus commonly dislocate inferiorly. So we will going to stop here today, and thank you for watching and listening the video carefully. And if you like the video, then please do not forget to like, comment and share, and do subscribe to the channel. Thank you so much.